Hi again. This is the second part of the two-part video series reviewing x-rays of the foot. In this video, we will discuss how to orient yourself to and interpret foot x-rays. First off, here are some basic rules that you can use for interpretation of any x-rays. I like to use the ABCs mnemonic, as previously described by many of my colleagues, in order to have a systematic approach that minimizes error. The first is A, which stands for adequacy. Some things that you can consider is this the right side? Is this the right patient? Is this the right view for the fracture that you may be concerned about? Is the film rotated? And you should evaluate for appropriate penetration. The next is B for bones. In this part, you should look for any obvious fractures, cortical irregularities, and, especially for the foot, identify any sesamoid bones. Next is C for clear spaces. In this section, you want to look at joint spaces, alignment, and in regards to the foot, you should evaluate Bowler's angle, which we will discuss a little while later. S stands for soft tissues. In this section, you want to assess for any free air, considering that the foot is made up of many joints, and free air may indicate an open fracture. And in this case, the patient may require tetanus, antibiotics, as well as possible consultation. You should also evaluate for any edema, which may lead you to an underlying cortical irregularity. And lastly, you should look for any foreign bodies. Okay, so let's start with A for adequacy. Part of adequacy is understanding the appropriate setting for certain x-ray views of the foot. I find that understanding which views are best for which part of the foot can help you more effectively read x-rays. The classic views of the foot are the anterior-posterior, 45-degree oblique, and lateral. The anterior-posterior or dorsal planar view is obtained by sending the x-ray beam perpendicular to the base of the third metatarsal. This view is best for the midfoot and forefoot. Next is the oblique view, which is obtained by everting the foot 30 to 45 degrees. This view is also best for the midfoot and forefoot. It is also the best view for evaluating the tuberosity of the fifth metatarsal. The AP and oblique views alone are sufficient if you are only suspecting a phalangeal fracture. Most times you will go ahead and order the third view, which is the lateral view. This view is obtained with the foot in dorsiflexion. It is the best modality for the hindfoot as well as the soft tissues. The Harris or axial view is obtained to evaluate the calcaneus. The calcaneus is the largest bone of the foot and accounts for the most commonly fractured bone. This view should be obtained to image the calcaneal tuberosity and the subtalar joint. CT has become routine in evaluating calcaneal fractures, and Harris views are being done less and less often due to CT capabilities in the emergency department. Next is B for bones. You want to make sure that you look at all the bones in the fore, mid, and hind foot in all three views. Seeing all of these bones in all three views is important, especially when evaluating for Lisfranc or hindfoot injuries, which we will talk about more in Grand Round's lecture this week. Whenever we are discussing x-rays of the foot, it is impossible not to discuss the sesamoid bones. Sesamoid bones are a normal variant in up to 30% of the population, and we will discuss some of the more common sesamoid bones that are often confused with fracture. These bones are differentiated from fracture by their smooth corticated surfaces. Radiographs from the opposite foot may be helpful, but keep in mind that these bones may not always be bilaterally. The first bone is the os trigonum. This sesamoid bone can also be confused for a posterior talar fracture. The next sesamoid bone is the os vesali, which can often be confused with the base of the fifth metatarsal fracture. Next, we have the os tibiale externum. This sesamoid bone is often confused with a cuboid fracture. Lastly, we have the os peroneum. This sesamoid bone is often confused with the base of the fifth metatarsal fracture or a cuboid fracture. Next, we move on to C for clear spaces and joints. Unlike the wrist, the foot only has one angle that should frequently be calculated by emergency medicine physicians. This is Bowler's angle. This angle is formed by two lines drawn on the calcaneus. The first line extends from the posterior tuberosity to the apex of the posterior facet. The second line extends from the apex of the posterior facet to the apex of the anterior process. If the value, which is indicated on this slide by the asterisk, is less than 20%, it is suggestive of a calcaneal compression fracture. The next clear space, or joint, that we need to evaluate is the Lisfranc joint. You want to be sure to evaluate this joint in both the AP and oblique views. Starting with the AP view, you first want to examine the first and second metatarsals with their respective cuneiform bones. Those cuneiform bones are the medial and middle cuneiforms. First, you want to evaluate that the medial border of the second metatarsal is aligned with the middle cuneiform. As we discussed earlier, the second metatarsal is the keystone of this complex, and disruption of the second metatarsal middle cuneiform articulation is one of the most diagnostic signs of a Lisfranc disruption. Next, you want to evaluate the first metatarsal with regards to the medial cuneiform. Lastly, on the AP view, you want to measure the distance between the bases of the first and second metatarsal. This value should be less than 3 millimeters. Next, you want to look at the oblique view. In this view, you want to look for normal alignment of the lateral border of the third metatarsal with the lateral cuneiform. Lastly, you look to see that the medial border of the fourth metatarsal is aligned with a cuboid bone. While it may be difficult to remember all of these exact alignments, a good rule of thumb is just to look down the medial and lateral borders of each of the first 4 metatarsals and make sure that they are aligning with their respective cuneiform and cuboid bones, paying special attention to the second metatarsal. Additional imaging of the foot may include stress views, used for joint instability, especially when evaluating for Lisfranc joint fractures or dislocations. You may also want to consider imaging the ankle to evaluate for fracture or joint instability, as well as the tibia and fibula. CT scan is becoming particularly useful for operative planning for calcaneal fractures, subtalar joint dislocations, and Lisfranc joint injuries. You can also consider MRI or radionuclide imaging. This concludes my 2-part video series on basic anatomy and interpretation of the normal foot X-ray. Hope to see many of you at Grand Rounds on Wednesday for our case discussions.